Welcome to Humanautic, unlocking the secrets inside your body and brain. Hello everyone. In today's video, we will discuss how to perform a hemorrhoidectomy, a surgical procedure used to treat advanced or symptomatic hemorrhoids that do not respond to conservative treatment. This explanation is intended for medical and surgical students, so we will briefly cover the indications, preparation, surgical steps, and postoperative care. 1. Indications. Hemorrhoidectomy is usually performed in patients with Grade 3 hemorrhoids, prolapse that requires manual reduction. Grade 4 hemorrhoids, permanently prolapsed hemorrhoids. Recurrent bleeding hemorrhoids. Thrombosed external hemorrhoids. Failure of conservative treatment such as medications or rubber band ligation. Common symptoms include bleeding during defecation, prolapse, pain, itching, and mucus discharge. 2. Preoperative preparation. Before surgery, proper evaluation is required. This includes history and physical examination, digital rectal examination, anoscopy or proctoscopy. Basic investigations like complete blood count and coagulation profile are also done. The patient is advised fasting before surgery, and bowel preparation may be given. 3. Patient position and anesthesia. Hemorrhoidectomy can be performed under general anesthesia or spinal anesthesia. The patient is usually placed in the lithotomy position. The perianal area is cleaned with antiseptic solution, sterile drapes are placed, and an anal retractor such as the Hill-Ferguson retractor is used to expose the hemorrhoids. 4. Identification of hemorrhoids. The main hemorrhoidal cushions are commonly located at 3 o'clock position, 7 o'clock position, 11 o'clock position. These are the typical sites where internal hemorrhoids develop. The surgeon identifies the most symptomatic hemorrhoid first. 5. Open hemorrhoidectomy, Milligan-Morgan technique. This is the most commonly performed hemorrhoidectomy technique. First, the hemorrhoidal tissue is grasped using artery forceps or Alice forceps to provide traction. Next, a V-shaped incision is made over the hemorrhoid using a scalpel or electrocautery. The hemorrhoidal tissue is then carefully dissected away from the underlying internal sphincter muscle. Once the vascular pedicle is reached, it is ligated using an absorbable suture, commonly Vicryl. After ligation, the hemorrhoidal tissue is excised distal to the ligature. Bleeding points are controlled using cautery or sutures. In the open technique, the wound is left open to heal naturally. It is very important to preserve mucocutaneous bridges between excision sites to prevent anal stenosis. 6. Postoperative care. After surgery, patients are monitored and given analgesics for pain control, stool softeners, high-fiber diet, adequate hydration, warm sitz baths. Most patients recover within 1 to 2 weeks. 7. Possible complications. Although generally safe, hemorrhoidectomy may lead to complications such as postoperative bleeding, infection, urinary retention, anal stenosis, rarely fecal incontinence. Careful surgical technique greatly reduces these risks. In summary, hemorrhoidectomy is the gold standard surgical treatment for severe hemorrhoids, particularly grade 3 and grade 4 disease. For surgical students, understanding the anatomy, careful dissection, and proper ligation of the hemorrhoidal pedicle is essential for successful outcomes. If you found this video helpful for your medical and surgical learning, make sure to like, share, and subscribe to Humanautic for more surgical education content.